Sorry, there was some technical glitch. So good evening, everyone. Welcome to today's webinar on first trimester screening, NT scan technique and interpretation. It is my pleasure to introduce our speaker for today, Dr. Raisa Samuel, an accomplished obstetrician and gynecologist. She has completed her MBBS, DGO, and MS in obstetrics and gynecology from the prestigious Christian Medical College, Vellore. She has also pursued a postgraduate diploma in family medicine from CMC Vellore, reflecting her commitment to holistic and comprehensive women's healthcare. With a strong clinical expertise and academic contributions in the field of obstetrics and gynecology, Dr. continues to play an important role in advancing women's health and medical education. We are very much delighted to have her with us today. Over to you, Doctor.
Thank you. My screen is seen, no?
Yeah, it's visible, Doctor.
So today's webinar is on ultrasound and obstetrics, specifically the first trimester screening. So in first trimester screening, I think most of you would have heard about nuchal translucency scan or NT scan. So how do we do it, and what is the technique to do it, and how do we interpret the values? So first trimester ultrasound are not a requirement for all pregnancies to confirm viability. So nowadays we always perform one scan immediately when the patient comes and for dating, and one we say for an NT scan, and then we advise a level 2 scan, that is anomaly scan, which we discussed last week. So it is not a mandatory thing that you have to do a first trimester scan. But however, if there is any high risk features, that is advanced maternal age, twin pregnancy, or if there is any clinical concerns like irregular periods, that if you have a doubt that the dating is not correct, the dates are not reliable, then if there is any vaginal bleeding, then more than one ultrasound may be performed, depending on, this is all clinicians' discretion, that you have to take a decision whether to do a scan or not. With the first trimester scan, ideally, the scan should be done between 10 weeks to 13 plus 6 weeks of gestation. Why? If you do a very early scan also, that is prior to 8 weeks or prior to 6 weeks, cardiac activity would not have come in prior to 6 weeks. Cardiac activity usually comes around 6 weeks. And 8 weeks and more is 8 weeks is good for a dating scan. But for an NT scan, it is better. It is advisable to do after 11 weeks. So in that case, you might have to do two ultrasounds in the first trimester. However, ultrasound exam before 10 weeks are common and can still be used as accurate assessment for most necessary clinical determination. So this is an additional scan to the dating scan. So what all are we going to see in this webinar? What is the NT scan? How is it done? The technique? How do we measure it? How do we interpret the NT? Early screening for chromosomal abnormalities. What are the first trimester fetal assessment essentials? And some practical tips. So first trimester ultrasonography, as I said, this is ideal time to do. If you are doing only one scan in the first trimester, then better you do it between 11 and 13 plus 6 weeks. What is the route? Both transabdominal and transvaginal scans can be performed in the first trimester. TVS is more useful for early pregnancy before 8 weeks in obese women, and also in women. If you're performing for an obese woman, it might be difficult to do visualize the NT or identify any anomalies. So you can use transvaginal scan. So women is in supine position for transabdominal scan and is dorsolaterotomy position for transvaginal scan. Bladder should be full for transabdominal scan and bladder should be emptied for transvaginal scan. This is something you have to keep in mind. So going on to our topic, screening for aneuploidy or chromosomal abnormality. That is why this scan has the importance. So what is nuchal translucency? It is an anechoic strip at the posterior fetal neck. So in the back of the fetus's neck, there is an anechoic strip, that is a fluid-filled strip is there, and this strip we are going to measure. So if the measurement is more, how do we interpret it? We will come to it. So the ideal time to do it is 11 and 13 plus 6 weeks. And the specification where the fetus should be in mid-sagittal plane, neck should be in neutral position, image should be magnified to fill the screen with fetal neck, head and upper thorax. Only this should be seen in the image. I will discuss further. So an accurate NT measurement requires strict adherence to the standardized international guidelines. So what we told now, these are all standard guidelines. So if you follow this standard guidelines and measure the NT, then only it will be accurate. So gestational age, it is always performed from between 11 weeks and 13 plus weeks, 6 weeks. And even sometimes when there is a date discrepancy, patient might be, by LMP might be 11 weeks. So, but might not, the CRL might not be crown drum length. The fetus might not be of that size. So you have to make sure that the crown drum length of this fetus should be between 45 millimeter and 84 millimeter. Then only you will get the correct value. Once it exceeds this, more than 84 millimeter, there is no, this value will not be reliable. So this is very important. This criteria should be followed. This standard has to be followed. Then only you will get a correct measurement. And the fetal head and the upper thorax should occupy at least 75% of the screen. Your ultrasound machine screen, the monitor should have only the fetal head and the upper thorax up to 75%. So this is the ideal thing. So you can see the most of the part is covered by the upper thorax. This is the upper thorax, and the fetal head is covering the whole 75%. So you have to zoom the freeze and zoom to this image should be there on your monitor. So here you can see this is the subcutaneous tissue. This is the skin, that is the back of the nape of the neck, the skin. And this strip is what we are going to measure. So here you can see the calipers that is placed, and the measurement is, this is the NT. This strip that is here is measured, and that is NT. And here you also see the nasal bone is also present. So image plane, it should be a perfect mid-sagittal view of the fetus is required. You must wish, so most of the time it is difficult for because the fetus is very small, it will keep moving. So sometimes the back might be anterior and the neck might not be visible. So we will have to get the perfect image, perfect view should be attained. So we will sometimes we ask the patients to walk and come back, and or take some fluid, so that you get the correct measurement. Even sometimes you might have to call them maybe after a few days if you are not able to visualize properly. So you must visualize the echogenic tip of the nose, the rectangular shape of the palate, and the translucent diencephalon. The nasal bone should be distinctly visible as an equal sign. Here you can see the nasal bone. This is the equal sign here. This one line and this one line. Here, this is the equal to sign. Neutral position, the fetus must be in neutral position. That is, the neck should not be hyperextended or should not be hyperflexed. So the neck should be in a neutral position. You can see here, the neck is in the neutral position. So what happens if the neck is extended more, the NT measurement will increase. And if the neck is flexed more, then the NT will decrease. So the neck should be in a neutral position. Again, care must be taken to distinguish between the fetal skin and the amniotic membrane as they look similar. So waiting for fetal movement or asking the patient to cough can help separate this. So here again, this is the fetal neck skin. So sometimes you might get confused with the amniotic membrane. So this if it is very close, if the liquor is less, then the amniotic membrane baby might be snugly closer to the amniotic membrane. So that's when we ask the patient to cough. So by coughing, what happens? The fetus might move a little bit and the amniotic membrane will move. So that will help to distinguish. So this skin has to be identified separately. Now, how do we measure? Once the correct image is captured, then you freeze the your monitor. So calipers must be placed with extreme precision. So this there is a technique is on-to-on technique, that is the cross of the calipers. The crosshairs of the calipers must be placed on the inner border of the translucent space, that is the fluid filled space behind the fetal neck, and the calipers should be perpendicular to the long axis of the fetal body. And the maximum thickness has to be measured. That is the widest part. Multiple measurements should be taken and the maximum reliable measurement is recorded. So here you can see this is the crosshairs of the calipers. This caliper should be placed from on to on. That is the inner, the line, this line you can see two lines are seen distinctively here. So it is placed from this line and this line, and this is measured. So here you can see this anechoic strip is extending from this point to this point. So you have to take multiple measurements and see which is the maximum measurement. Here it is quite obviously seen that this area is widest. So here you place it and you take the measurement. That is how you measure, and it should be perpendicular measurement. Do not take slanting measurement from here to here or anything. It should be exactly perpendicular measurement. And here you can again see nasal bone is seen. This nasal bone, this is the nasal bone, this is the equal to sign, the bone. And neck, you can see it is in neutral position. This is the mid-sagittal plane, and you can see that neck is not hyperflexed or hyperextended. It is in neutral position. It is quite difficult to get this position of the fetus. That is the challenge. Nuchal translucency, how do we interpret? Now we have got the value. So increased NT is usually associated with trisomy 21, Turner syndrome and other chromosomal defects, as well as cardiac anomalies also. So normal NT measurement is generally considered to be 3.5. Some books say even more than 3 is also abnormal. So NT is usually combined. NT as such, if it is raised, is not, we also do biochemical testing along with NT and for chromosomal anomalies. So also other ultrasound markers are also seen if there is absent nasal bone, if there is increased impedance to flow in the ductus venosus, and if you see tricuspid regurgitation. These are all other ultrasound markers which we see in the first trimester scan, which are abnormal. So if your NT is less than 2.5, that means it is low risk, it is normal, standard. So routine combined screening pathway is taken. If it is 2.5 to 3.4, then it is borderline or intermediate. So what do? We review with maternal biochemistry. We look at the other values and see whether it is high risk or anything, and then you do a follow-up scan. If it is more than 3.5, then that means it is increased risk or high risk. Here you have to offer them invasive testing like chorionic villus sampling or early cardiac scan. If it is cystic hygroma, that it is a gross swelling or gross fluid fill area in the nape of the neck, that is pathological, and urgent genetic testing and microarray analysis has to be done. If the diagnosis is confirmed, then termination should be advised for cystic hygroma. So this is a normal NT. Here you can see an abnormal NT. Look at this distance from this to this. This is around, it's not very clear, but definitely it is more than 3.5 millimeter. Here again, you can see this is a normal nasal bone. Here there is no nasal bone, absent nasal bones as seen in trisomy 21. This is how the nasal bone looks. Here nasal bone is not visible, and here the NT is normal. Here you can see that the NT is increased. So early screening for chromosomal anomalies or abnormalities, the NT scan is primary. It is a screening tool. You should know that this is not a diagnostic test. It is only a screening tool. It is used to assess trisomy 21, that is Down syndrome. So an increase NT is usually associated with Down syndrome. Trisomy 18, that is Edwards syndrome, and trisomy 13, that is Cotto's syndrome, also frequently present with an elevated NT, but it is often also accompanied by other structural anomalies like or absent nasal bone. So all these three are screened with combined screening to increase the accuracy. NT measurement is combined with maternal age and blood serum markers. So we tell the patients the day you are doing your NT scan, because NT scan is a challenge, you might not be sure that they will be able to perform it on the day that you have asked them to do. Sometimes they might be called again. So once they come with the NT scan report, the NT measurement report, that same day you should advise the patient to give their blood for these serum markers. So PAPE and free beta HCG is the test, that is biochemical markers that we do along with the NT scan. And this combined test yields a high detection rate of approximately 85% to 90% for Down syndrome. So once the screening has come back as positive, that is, if it is 1:250 is the cutoff that we take for Down syndrome, if that is showing that is high risk. So if it is 1:250, then you should advise them to go for an invasive confirmative test, which will give you the actual whether the fetus has this Down syndrome or not. It is confirmed by the confirmatory test or invasive test, amniocentesis or chorionic villus sampling. If it is up to 14 weeks, 13 plus 6 weeks, you should advise them chorionic villus sampling. Beyond that, we will advise amniocentesis. So first trimester, this is how we measure the NT, how do we interpret it, and how do we manage increased NT. So what are the other first trimester fetal assessment that we do along with this scan? So fetal viability is the first thing that we will do. We will identify whether it is an intrauterine pregnancy or not. Pregnancy dating, if we have not done a pregnancy dating at around 8 weeks, or how to do a dating scan, that we will see. Multifetal pregnancy, again, if how to determine the chorionicity, whether it is dichorionic or monochorionic, depending on the first trimester scan is the best time. This is the best time to determine the chorionicity, and screening for aneuploidy, which we have already explained. So establishment of viability, routine scan before 11 weeks is not recommended unless if there is a menstrual irregularity and you want to be sure of the date. Exact date of LMP is not known. If the woman was on OCPs and you want an accurate date, if you have a difficulty in confirmation of pregnancy by physical examination or pregnancy test, that is UPT is not giving you it's not accurate. Doubt as to location of pregnancy, that is whether you have any doubt whether it is ectopic, and if there is any early first trimester bleeding in pregnancy. So term viability is used when the cardiac activity is demonstrated in the embryo or fetus by transvaginal scan. That is when you say that cardiac fetus is viable, means cardiac activity should be present. So usually cardiac activity is present when the embryo size is around more than 2 millimeter, but sometimes even at 2 to 4 millimeter in 5 to 10%, it might not be present. So we usually call them maybe after 10 days to do a repeat scan and see. Once the embryo has reached up to 8 millimeter, if the CRL is 8 millimeter and you are not able to see cardiac activity, then we will tell it is non-viable. Assignment of gestational age or dating scan. Dating is by CRL, that is the crown rump length. Once the gestational age is assigned, that is the previous, if the patient doesn't know LMP or is not sure of dates and you are using the scan as for dating, and you also see that there is discrepancy, you should never change the age, gestational age, depending on the further scans. Once dating scan is done and you have fixed the EDD, that should never change with the further scans. So first trimester scan is the most reliable scan for dating. And this on basis of this, we will assess the fetal growth, the timing of procedures, and also if you are planning for a cesarean or planning for induction of labor, then the date should be calculated based on this first trimester scan. So this is how the first trimester scan. This is the gestational sac. You can see the embryo is here. So the gestational sac measurement is around 1.55 centimeter, which is corresponding to 6 weeks and 3 days. So you can see the measurement. This is the measurement. This is the embryo. Here you can see the yolk sac is formed. The yolk sac is measured, which is around 0.20 centimeter. Now, how do we measure the CRL? Here you can see from this end to this end, CRL is 0.732 centimeter, which is corresponding to 6 weeks and 5 days. Here, the cardiac activity is come. So, once you put the Doppler, you can see that 120 beats per minute, it is giving. So, cardiac activity is come. So this measurement from this end to this end, that is the crown to the rump length, which is a vertical line, a horizontal line that you put, will give you the gestational age. So evaluation of gestational sac, small anechoic fluid film surrounded by an echoic ring that represents trophoblast and decidual reaction that forms the gestational sac. It's usually seen by transvaginal scan when even if it is very small, 2 to 3 millimeter, you will be able to see it by TVS. It is clearly visible at 4.5 to 5 weeks. That is up by 5 weeks, you will be able to see the gestational sac. Usually eccentric in location. It is surrounded by 2 rings of decidua, that is called the double decidual sign. Good decidual reaction you might have seen. That means there is 2 rings of decidua. Here you can see this the hyperechoic area around the gestational sac. This is the decidual reaction. This is a regular looking gestational sac. This is the endometrial cavity. This whole thing is the uterus. So here you can see clearly this is the decidual reaction, the surrounding area of the gestational sac. Gestational sac is evaluated for the presence or absence of yolk sac and embryo. Before 5 weeks, embryo is not seen. By 5 plus 5 weeks, embryo is identified as a 1 to 2 millimeter structure. So here you can see this is a irregular looking sac with, you cannot see any embryo. There is no embryo, there is no yolk sac, and it's already this corresponding to 9 weeks and 3 days. And when you are not seeing a embryo or a yolk sac, that means this is likely to be a failure, pregnancy failure. Here again, you can see that this is an irregular looking sac, and even this this embryo is also not very irregular, and most probably this is a missed abortion. Cardiac activity would not have come in this. Yolk sac is the first structure that appears within the gestational sac, the G-sac. It should be visible when the mean sac diameter is 20 millimeter by trans-abdominal scan or 8 to 10 millimeter by transvaginal scan. Presence of yolk sac is indicative of an intrauterine pregnancy. Normal yolk sac is usually less than 6 millimeter. If you have a very large yolk sac, that means it's an abnormal pregnancy. As pregnancy advances, this yolk sac will disappear and it is usually not seen beyond 14 weeks. So here you can see this is very clearly seen. This is the gestational sac, this is the yolk sac, and here this is the fetal cord. And you can see the decidual reaction around it. This is once double. You can see the double reaction around it. Crown drum length, as I said, it is a longest straight line measurement of the length of the embryo or the fetus. You should not take the limbs and the yolk sac. Measurement is from the top of the head, that is the crown, to the bottom of the buttocks, that is the rump. CRL is the most accurate estimate of gestational age and should be used to calculate the EDT. CRL less than or equal to 8 to 8 plus 6 weeks. Sorry, more than 8 to 8 plus 6 weeks is the most accurate in determining gestational age with range of plus or minus 5 days. So if you are want to advise a patient for a dating scan, best time is to do is between 8 weeks and 8 plus 6 weeks. This is the best time to do the dating scan. Measured between 9 and if the patient has already reached 9 weeks and around 13 plus 6 weeks between this time, then the accuracy again decreases. Here the accuracy is around plus or minus 5 days. Here it is plus or minus 7 days. Then beyond that, you have to take more than 14 weeks or more than 84 millimeter. You have to take BPD, is used for gestational age. So here you can see the longitudinal view. So you locate the head and the rump. This is the head and this is the rump. Limbs are here, so you should exclude the limbs, the head and the rump buttocks. The embryo will often be in a C-shaped curvature. This is how the embryo is usually. Straight line measurement using the calipers on the ultrasound machine to measure a straight line from the outer margin of the head to the outer margin of the rump is taken. From the calipers is placed here and the other point is placed here and then you measure the straight line. This will give you the crown drum length. The straight measurement from here to here. Now going on to multiple fetuses, number of fetuses is documented. In case of multiple gestation, chorionicity should be reported. 2 placenta means dichorionic twins. Transvaginal scan between 11 to 13 plus 6, it gives around 95 to 100% sensitive in determining the chorionicity and amnionicity. So if a twin gestation patient comes, you have to advise them to come between these weeks to determine the chorionicity and amnionicity, because this is the period when it is highly sensitive. Between 6 to 10 weeks, you usually see 2 G-sacs. That means DCT, it is dichorionic twins. Thick dividing membrane is seen. Single G-sac with single yolk sac but 2 fetuses means it is monoamniotic. Then further, here is the image. Here you can see this is a single sac and single gestational sac with 2 embryos. This is monoamniotic twins. Here you can see separately 2 gestation sac is separate. Even the amniotic sac is separate. So this is diamniotic, dichorionic, and the dividing membrane is thick. I hope you are able to appreciate this. 2 separate sacs, 2 separate amniotic membrane also. So this is and there is thick dividing membrane. So if it is single placenta, that means it is both seen in both dichorionic and monochorionic also. It could be single placenta. If it is 2 placenta, that means it is dichorionic. Only in dichorionic you can see that is dichorionic, diamniotic. You will see both 2 placentas. Between 11 and 13 plus 6 weeks, a triangular projection of the placenta is seen, because placenta also starts developing and is developed during up by 14 weeks. Placenta is developed. So that is why this gestational age is important to determine the chorionicity. So if a triangular projection of the placenta is seen between the two layers of the dividing membrane near the placental surface, this is called the twin peak sign or lambda sign, which is seen in dichorionic diamniotic twins. So this dividing membrane, as I showed here, is quite thick, more than 2 millimeter thickness will this membrane. So you measure and see it will be more than 2 millimeter thick, and it will have 4 layers. That is, it will have both the twins is chorions and both the twins is amnion, 2 chorions and 2 amnions. So that is why this dividing membrane is thick, and this is called twin peak sign or lambda sign. In MCDA twins, that is monochorionic diamniotic twins, there will be no projection of the tissue between the layers, and the membranes will join the placenta at right angles. This is why the dividing membrane will be less than 2 millimeters. It is has only 2 amnions, that is 2 layers, and the fetus is usually and this sign is called T sign. If the fetuses are of 2 genders, then it is definitely dichorionic. So I'll explain here clearly. So here you can see this is dichorionic diamniotic twins. Here there will be 2 amniotic sacs, and it will have 2 chorionic sacs also. So the membrane will be thick. So they will have 4 membranes together, and that will be more than 2 millimeter, and this is called the lambda sign. That is dichorionic diamniotic. In monochorionic monoamniotic, what happens? It has only 1 chorion, but there is 2 amniotic sacs. The amniotic sac will be 2, but the chorion is only 1. One thick chorionic sac surrounding both the embryos. Each embryo is surrounded by thin amnion. So there is 2 yolk sacs are seen here. You can see 2 yolk sac, and this is the membrane. You can see amniotic membrane, 2 separate amniotic membrane. In monochorionic monoamniotic twins, what happens? It is all of it is inside one amniotic cavity. Amniotic sac is both the fetuses. So most complicated twins is monochorionic monoamniotic, because they share the same amniotic sac. So when you have a twins class, you will know that this is the most complicated twin, that is monochorionic monoamniotic. So it is very important to identify what kind of twins it is, the chorionicity and the amnionicity, by scans to predict the complications. So you have to twins as such is complicated pregnancy. So depending upon the chorionicity and amnionicity, they are all the complications increases if it is a monochorionic monoamniotic. And as you know, all TRAP, a twin-to-twin transfusion syndrome, all this happens in monochorionic monoamniotic twins. Vanishing twin, entangling of the cords, all this happens in monochorionic monoamniotic. So it is very important to identify this, what is the chorionicity. So this is the lambda sign. Here you can see this membrane is quite thick. This is definitely more than 2 millimeter. And you can see there is separate, it is a separate chorionic sac and separate amniotic sac. So that is 2 amnion, 2 chorion, which forms this thick membrane, which is the lambda sign, dichorionic diamniotic. This is diamniotic, monochorionic diamniotics, 1 chorion, but 2 amniotic membrane. So this is the T sign. Now going on to fetal anatomy. Early opportunity for systematic study of fetal anatomy. Fetal anatomy in detail we had in the previous webinar. It is usually done at 2nd trimester, but this is it doesn't mean you should ignore the this does not mean that you should not look at the fetal anatomy in the 1st trimester. There are so many anatomy anomalies that can be identified in the 1st trimester, which are lethal, fatal to the fetus, and should be advised termination by first trimester scan itself. So more structural information you will get once the CRL is around 42 to 84 millimeter. Some fetal anomalies like acrania, anencephaly especially should be identified in this first trimester scan when you are doing an NT-NB scan. This definitely is something, one anomaly that should, if present, should be diagnosed. It should not be missed in this scan. Lobar, holoprosencephaly, exophalos, gastrochisis, megacystitis, and gross limb reduction defects. All this can be identified. These anomalies can be identified in your first trimester scan. So, minimum things which you should see in the first trimester scan: head and brain. You look at the axial view of the head, calcification of cranium, contour or shape of cranium has to be seen with no bony defects. Two brain halves separated by the interhemispheric forks. Choroid plexus almost filling the lateral ventricles in their posterior two-thirds. This is called the butterfly sign. And neck, you have to look at the sagittal view of the neck. We are looking at the nuchal translucency thickness we are measuring. Heart, you look at the axial view of the heart at the level of forechamber, and heart, just look at, see whether the heart is inside the chest with regular rhythm. This is something which you have to identify. Abdomen, stomach is usually visible, intact abdominal wall, axial or sagittal view, bladder should be visible and not dilated, megacystitis should be ruled out. Extremities, you visualize 4 limbs, each with 3 segments, and placenta also a certain normal appearance without any cystic structures. So here you can see the nasal skin, the nasal bone, the tip of the nose, palate is seen, thalami, midbrain, brainstem, medulla oblongata, fourth ventricle, and nuchal translucency. This much you will get from the first trimester scan in the fetal head anatomy. Fetal brain, you look for choroid plexus, lateral cerebral ventricles. You can see the third ventricle is here, aqueduct of Sylvius is seen here. And this is the neck, this is thalamus, the brain stem, all this is seen in the brain. Here you can see the spinal cord. You look for any neural tube defect of the spine. This is a first trimester scan of all the fetal anatomy that is seen. The head, the thorax, brain, again the nuchal translucency, the brain different levels. Here you can see the abdomen. This is the heart, four chamber view of the heart. You see here you can see the abdomen, the stomach bubble, again the heart. Spine is seen clearly, the extremities, limbs. Here you can see the limbs, hands. So this is anencephaly or acrania. Here you can see there is no head. The skull bone is not complete. So they typically present with this frog eye sign. You can see the frog eye sign. And this is the lip and the nose. This is a neural tube defect that is identified by in the first trimester scan. Projection from the brain. Here you can see this is projection from the brain. Here at the spine, this is the image of this. From the spine, there is a bulge outside. Also, along with that, uterine anatomy and adnexa also should be seen. Uterus should be evaluated for anomalies. This is the first trimester scan, so you have to take a careful look at the uterus and the adnexa. Presence of any fibroid. If it is present, what is the size, type, and location? If it's an intramural fibroid, then there is chances of red degeneration during pregnancy, so you have to measure their size. If it is in the lower segment, then again difficulty during chances of malposition, preterm labor, again need for cesarean section, and during cesarean section there might be complications because of the fibroid. So if there is fibroid, that has to be checked and mentioned, also reported carefully. Adnexal masses, if there is any adnexal cyst, any cyst in the ovarian cyst, or should be mentioned. Again, uterine anomalies like biconjugate uterus. So here you can see this is the left horn and the right horn. The pregnancy is in the right horn. This is the gestational sac which is in the right horn. So it is you have to mention what if there is a biconjugate uterus, which horn the pregnancy is for the further continuation of which will be helpful in the further continuation of the pregnancy. Here you can see this is more like a uterine didelphys with a pregnancy in the one of the horn. This is a large myoma fibroid which is present along with pregnancy. You can see this is a fibroid. Ovary is seen on the side. Now coming to the last topic, that is uterine artery Doppler. So uterine artery Doppler is also performed along with the first trimester scan, that is during 11 to 13 plus 6 weeks. So here you are looking at assessing the maternal vascular status at the level of the internal os. So the uterine artery, which is the cervicocorporeal junction before branching. So it is the artery that is closer to the, which comes and joins the cervical artery. So this branch of the uterine artery is measured for the Doppler, and mean pulsatility index is taken. Why is it significant? This will give you an idea of how the perfusion or how the uterus is trophoblastic, if there is any impairment in the trophoblastic invasion, and if there is any high resistance. So this is a predictive for predicting whether there is a possibility of patient developing preeclampsia. So preterm preeclampsia, so early onset of preeclampsia can be predicted by doing this uterine artery Doppler. So usually we combine this with the PI of this uterine artery is combined with mean arterial pressure, that is the blood pressure, mean arterial blood pressure of the patient, and the PIGF value, that is a biochemical marker, and this will give you a for more than 90%, it gives accurate detection of preterm preeclampsia. So along with your down screening, nowadays we always advise patients with combined screening. Along with that, we also include a preeclampsia screening for all patients. It is offered. It is not compulsory, but it is offered, which is actually predictive of whether that patient has a chance of developing preterm preeclampsia. It also will predict whether could be any early onset IUG or FGR also could be predicted along with prediction of preeclampsia. So once this comes back as high risk, if the patient is at high risk for developing preeclampsia, those patients we ask them to have a strict monitoring of their blood pressures. Also, we start them on ecospirin 150 mg as a prophylactic dose. We start them on aspirin. So this is actually second trimester scan, but this is how the normal uterine artery looks like. The Doppler is normal. If it is, the PI is high, you can see there is high, and also there is a notching. This is the notching of the uterine artery. In the diastolic notching, this is called. Systolic is this, diastolic is this. So this dip here is called as a diastolic notching. This again is predictive of preeclampsia. So that is all. Thank you. Questions?
Doctor, there's already one question in the chat box.
Okay. How whether placenta is posterior or anterior with help of image? Placental localization, I think the previous webinar I have covered. Image, I'll have to share that other PowerPoint. Otherwise, we can have anyway, one more scan will be there, no? One more session will be there. In that, I can clear the placental localization. Nuchal fetal scan, not understand. Nuchal translucency or meaning? Nuchal translucency is this, what I explained now. You want me to repeat it? I'm not understanding what your question is. Do you want me to repeat how to measure the nuchal translucency? So this is the nuchal translucent. This is the anechoic fluid filled space which is present on the fetal neck. It is present in all fetuses. It should be there. It will be there. And you measure this, the widest point that you have to measure from these two lines. You can see from here. You have to keep measuring all this area you measure, and whichever is the widest, that is the largest measurement that you get, that is the accurate measurement. And it has to be perpendicular, no taking it diagonal or from this end to this end. No, it has to be perpendicular, and it has to be, this cross has to be on the, you can see it is right on the inside, and this also right on the inside. That is the on to on technique. Okay, then we measure this. If it is more than, I already explained, 2.5 is fine. 2.5 to 3.4 is borderline. More than 3.5 is abnormal. Some books say also 3. Anyway, if it is more than 3, I think, and along with that combined screening, if it is more, then you should go for a invasive testing. That is chorionic villus sampling. Any more questions? How to find out uterine artery easily? That is only with experience only you will get uterine artery. Doing Doppler is not easy. Doing Doppler is a little quite difficult. Doppler, how to do Doppler again is another session. We can take another one more session.